For me?
For you.
Please.
When you were speaking about ovarian, urinary carcinomas, you stressed upon villous and non-villous papillary hyperplasia. I have one more idea about it. Papillary hyperplasia, you was speaking about villous and non-villous papillary proliferation. What are the differences and what are the values?
Okay. The term villus, I use it only for description. It is in the literature, what would I say, viloglandular carcinoma. It's in the literature. You'll see it. It's part of the WHO probably. I do not use it as my diagnosis. I would say with viloglandular features, okay? Because it is FIGO grade 1. The most important thing, and the one it is correlated for prognosis, is the grade. And we use FIGO grade, either 1, 2, or 3. Viloglandular, it is FIGO grade 1. And the other thing, it is in the differential diagnosis of serous because of the papillary, but the lining is what would distinguish between both. This is the first part of the question. The second one regarding the hyperplasia, in the literature it is either complex or simple, and it is with atypia. But sometimes it does not read the book. You got a patient with this papillary configuration that the glands are like too many of them, so I had to give it a diagnosis. You agree? So this is why we call it endometrial papillary hyperplasia. Okay, and I always put a comment and describe what did I see, and most of the time, either I get a call or I call my gynecologist explaining to him, because they might get confused. What does it mean? What is it for the patient? What's the prognostic value of it? So I can educate them and call them explaining that. Okay, thank you.
Okay, dear colleagues and respectable attendants, we are lucky enough to have Professor Ruwa once again in another lecture entitled Contemporary Issues in Ovarian Carcinoma.
Okay, thank you again. Thank you so much for staying here. I know it's Friday and it's the day, the holiday. Probably it's beautiful outside. It's very warm for me outside. Remember, I come from Michigan, and the temperature 2 weeks ago was -20. And they put it in the news that our temperature was colder than Mars. So for me here, it's summer and it's vacation. So thank you for the invitation again. It's a break for me. And it's wonderful to be with you here. And I have to disclose this and tell you, some people were asking me where I'm originally from. I'm from Syria originally. And it's kind of very emotional for me to be here, and my parents are in Syria. So I'm so close to you guys, and I wish all of you that you will pray. Thank you so much, and hopefully we'll pray for peace in Syria. It went completely, yeah, thank you so much. Okay, moving gears to the ovary. And and I know it's a little bit dry at the end of the day to talk about ovary, and especially the pathogenesis of ovary, and what's the up-to-date, what's the original of ovarian carcinoma, and is every ovarian carcinoma is a deadly disease? No. And just stay with me. I know it is tough after 3 lectures, but let's go over the journey together, and you can stop me anytime, okay? And I love it that it'll be more interactive together. I like this cartoon since I was in the medical school, and it's remind me of what's the original, any origin of any carcinoma. And always we have to think as this is the ovary. So this is very old cartoon that it could be epithelial, so it could be carcinoma, germ cell tumor, sex cord stromal tumor, and the metastasis. So I always, whenever I have ovarian mass, especially in the frozen diagnosis, in the frozen room, that you have to be so fast. So think about all of them at the same time and ask the surgeon, call them. And you need to know the clinical history before anything else. How old is the patient? Is it unilateral? What's the symptoms? CA125, any markers for germ cell? So clinical, it helps you all the time. So this is part of the frozen. But moving to the ovarian carcinoma, the individual lifetime risk for any ovarian neoplasm, 5 to 7%. And the individual lifetime risk for ovarian carcinoma is only 1.7%. I know it's very small, but it's very scary, you know. So the risk that adnexal mass is malignant in the premenopausal woman, 7 to 13, it jumped to 30 to 45% in postmenopausal women. So I hope, I have to disclose this with you. Last night I was playing with this, and in the middle of the night I panicked. My Mac, supposedly all the Mac, they are wonderful and they were great. This turned white completely and I lost my PowerPoint. I was planning to call Iman, and I'm like, what would I do? I called my son through Skype. He helped me. Can you believe it? It's a small village, the whole globe. But if there is any slide in or out, because I did not look at them very closely. Okay, the pelvic mass workup, it's always, as I said, the personal and family history, physical exam, lab evaluation, and radiological images. And I'll try to cover quick with you the pathogenesis of ovarian carcinoma, the two types of ovarian carcinoma, type 1 and type 2, histology and grade, and the fallopian tube phenomena, and quick about prevention. So by now, most ovarian carcinoma present in advanced stage. I'm not saying anything new. Do you agree? It is, always. But survival for stage 1, even if it is very small, that we see stage 1, it's 90%. So the big question, and so many effort was put in the research arena, in all the clinical trials, everywhere, to see, can we pick ovarian carcinoma in stage 1 or not? Well, unfortunately, so far, not. Because the serum markers, like CA125, still it's not sensitive and specific. If you have any inflammation, if you have endometriosis, it goes up. So it's not specific for ovarian carcinoma. Vaginal ultrasound, it's not that successful, and we cannot do it to every single woman. And why is that? Can we do something as a pathologist? Well, Dr. Kerman probably now 10 years ago tried to classify ovarian carcinoma to type 1 and type 2, and to put some light for the pathogenesis and the molecular differences between both of them, because each one of them is different prognosis. We can detect them earlier in type 1, so at least we have part of this ovarian carcinoma, we can detect them in early stage. So type 1, it is low-grade serous, it's low-grade endometrioid, mucinous clear cell malignant Brenner. Type 2, high-grade serous, high-grade endometrioid, MMMT or carcinosarcoma or undifferentiated carcinoma. So looking grossly, this is high-grade serous carcinoma. Most of the time it's present as omental cake, we call it, because it's metastasized, it's in the peritoneum right away. This is the way it presents. And this is high-grade serous carcinoma type 2. Type 1, it's completely different. It presents like endometrioid carcinoma in a cyst. Agree? Most of the time you have it, even the low-grade endometrioid in stage 1, and it arises from endometriosis. So the presentation is different. Grossly, they are different. Clear cell, it's in type 1 in the ovary, also present as a cystic mass or a mass. It's not in the omentum already in early stage. So the same for mucinous. It's heterogeneity. This is the key. This is why I want to tell you. How about under the microscope? Low-grade serous carcinoma, it is different from mucinous under the microscope. You agree? And I'll put higher, just to give you an introduction about how do we look at all of them in general. So they are heterogeneity, morphological was, the type 1. They don't look alike. They're low grade. The only thing in general they all have that it's not mitotically too active. They are malignant though, but I'm not saying that they are popping mitosis left and right and the severity of the cytologic atypia. So low-grade cirrus is completely different look from the mucinous that you have here and the endometrioid or the clear cell. However, under the microscope, the high grade, if it is cirrus or endometrioid, they all have one thing in common: the high rate of mitosis and the very significant cytologic atypia. So they are morphologically more homogeneous. And the pathogenesis of it, or where did they, the difference between type 1 and type 2, that type 1, it is stepwise progression. It has a precursor that it is well established. Like in the cirrus, in low-grade serous carcinoma, what's the precursor for it? It's the borderline. So if we have borderline carcinoma, and I have one of the cases in my second lecture, my next lecture, so it might progress to low-grade serous carcinoma. In the endometrioid, a typical endometriosis might progress to endometrioid carcinoma. So we have a well-defined precursor lesion for type 1. How about type 2? If we understand the precursor, we can pick it up, right? It's still debatable, and I'll tell you about it. I should say debatable, not identified, because this is what I'll be talking about. So this is the difference at the top. This is type 1. It starts from in the serous, cystadenoma, serous borderline tumor, to low-grade carcinoma. In the type 2, it's either from the fallopian tube or from the inclusion cyst, and I'll tell you about it. It gets hit by the p53 mutation and progress to high grade right away. And it goes outside to become advanced stage. So this is at the clinical. What about, this is for the low grade and the high grade. There are distinctive molecular genetic changes between both of them. The low grade, they have one thing in common: KRAS-BRAF mutation is high in the serous borderline, the precursor, and low grade serous carcinoma, and very low p53. And it is opposite to the high grade serous carcinoma, which is so high in p53 and low in KRAS-BRAF mutation. So there are two distinct diseases even under the molecular pathology. So this is another cartoon. This is kind of a new, telling exactly or the difference in the high-grade serous carcinoma that it has p53 mutation and chromosomal instability, and the BRCA1 and 2, different from the low-grade that it has KRAS-BRAF mutation, and each one of them it has different at the molecular level. This is a quick, I won't bore you with a study we did differentiating between type 1 and type 2, and our cohort in our hospital read really the book that low grade or type 1 did way better than type 2, and we had them inflammatory markers. Sorry. The inflammatory markers differentiate between type 1 and type 2 was statistically significant. It was COX-2, INAS, and COX-2, and COX-1. So what's the pathogenesis of low-grade carcinoma? And this is another very elegant study. I know it's a long time ago. They did laser microdissection of the cystadenoma and the borderline. Look at this. This is a cyst. This is the epithelium from here, and this is the epithelium from the borderline, and this is after the microdissection, and it has identical mutation differences. They were identical. Identified, I meant. How about a mucinous carcinoma? Again, it has a precursor lesion. It starts as a mucinous adenoma, a typical proliferative, intraepithelial carcinoma, a typical proliferative, the same as borderline tumor, mucinous carcinoma, and invasive mucinous carcinoma. It's stepwise fashion. It's the same as borderline endometrioid, ovarian endometrioid carcinoma is similar. I have to say that not every endometriosis will develop carcinoma. Absolutely not. Right? You have to have the genetic abnormality, the mutations, the atypical endometriosis. The rate is less than 1%. Because endometriosis is very common, do you agree? Like almost every other woman has endometriosis. But you have to have all of these mutations to develop the low-grade endometrioid adenocarcinoma. And actually, we studied that ovarian carcinoma associated with endometriosis, they'll be early stage, right? And so they'll have better prognosis than others without endometriosis. So in a way, it's a blessing when you have ovarian carcinoma. All right, so what's the pathogenesis of high-grade serous carcinoma? What's the big heat about fallopian carcinoma? Again, if we understand the origin, we can treat better, right? We can detect better. Think about at the time of the ovulation, what happened. The fallopian tube, it's literally the fimbria as the finger projection. And look at it here. It hugs the ovary, right? And at the time, this is the fimbria, fallopian tube, and the ovary. At the time of the ovulation, this is the surface of the ovary. The oocyte will be ruptured, the surface, right? And there'll be a wound, and it'll attract all the interleukin and all of these molecules that it'll be inflammatory, right? So let's go to the second one. Look at this one. So the fimbria will shed some of the secretory cells. Remember in the fimbria there is 3 types of cells. The secretory, the cilia, and the Picca cells. So it is the secretory cells. It'll, in that wound, will go deep in the surface of the ovary and will make the surface epithelial inclusion cyst, where everyone is thinking this is the origin of high-grade serous carcinoma. And I'll show you more. And this is a real one. My next slide, by HNA and the fallopian tube epithelium and the serous carcinoma, they share the PAX8, which is a marker. It is significant for the fallopian tube surface and the Mullerian aspect of the ovarian carcinoma. It's not at the surface of the ovary, where everyone was saying it's from the surface of the ovary. It's not. It's calretinal. It's mesothelial here. It is focally positive. It's completely positive here as well. Okay, it's just to give you that the origin of high-grade serous carcinoma ovarian, it's from the fallopian tube. You know, and this is the new, like kind of the up-to-date, where is this high-grade serous carcinoma coming from? It's coming from the fallopian tube. And again, sometimes you see with the ovarian serous carcinoma, fallopian tube carcinoma, and the association is very high. And if you look at the normal fallopian tube, you look at P53 signature, it's benign appearing epithelium, but positive for P53. It got knocked by the mutation. It will progress to TIC, which is serous tubular intraepithelial carcinoma, and develop serous carcinoma. And I'll re-emphasize on it again and again. Again, look at this is normal. This is from the fallopian tube. It starts becoming abnormal. It is serous. And it is so similar to the endometrial serous carcinoma. Do you agree? It's almost identical here. The hobnailing, the little debris here. Look at it here. And again, or here, I do P53. Okay? And look at the P53. It is positive. And this is P53 signature. It's benign looking epithelium, but P53 positive. It develops TIC, which is serous tubular intraepithelial carcinoma. So this is the cartoon explaining the story. And the story is the benign tubular epithelial from the secretory cells. This is in the fallopian tube. Okay, either it will shed and make endosalpingiosis, or surface epithelial inclusion cyst. And if it gets hit by P53 mutation, you'll get the P53 signature, and then ovarian serous carcinoma. Okay, and then it might metastasize outside. It could be either in the fallopian tube, or it might be in the ovary, or even if it is in the omentum, it's the same disease. And the new trend now to call it pelvic high-grade serous carcinoma. Because who cares? If it is in the fallopian tube, or in the ovary, or in the peritoneum, it's the same disease, the same treatment, the same prognosis. Okay? So one more time. Type 1, low grade, it's different genetic abnormality. Type 2, P53 mutations, different pictures under the microscope or at the molecular level. So, is it important to differentiate between, as I said, histology is very important, and our job is really crucial for the oncologist. Because, as I said, mucinous behaves different from clear cell, different from high-grade serous, different from low-grade serous. So, as I said, each one of them reflect distinct disease entities. Agree? Just talked about it. The diagnostic criteria for each one is different. And then the grading, it's very important. Personal and family history as well, and for the therapeutic relevance. So, as I said, one more time, why the emphasis on it? It's not only for being disease. Look at the chemosensitivity, the treatment. I'll go straight here. High-grade serous carcinoma is chemosensitive. It really responds to chemo better than low-grade, better than clear cell carcinoma. Clear cell carcinoma resists chemotherapy with all the classic protocol everywhere. And let's look at 5-year survival. It's completely different. It's almost curable in endometrioid, and clear cell stage 1 is 75 mucinous, almost ovarian mucinous, almost curable. Look at the high-grade serous, I'm losing the pointer, 40%, and in advanced one, 20%. So each one has different clinical pictures. This is why we have to distinguish between each one of them. Let's do some H&E. And sometimes, believe me, not very easy. It's not black and forth, and we'll look at some cases. So serous carcinoma. If I have this in the gross, can I tell 100%? I might guess, honestly. But I have to have the section. You agree? If I have a mental cake, always I think about it. It's high-grade serous. What's the highlight of it? It's the papillary, it's the high proliferative rate, mitosis, you might see apoptosis, the slit-like, the nucleoli. It's a high-grade malignancy. Looking at this, emphasizing on the nucleoli and the mitosis and the slit-like. I don't think anyone will have problem with high-grade serous carcinoma. Another case, it's just beautiful to take more pictures, especially about pathologists. There is one variant I like to give, and one of our pathologists described it. It's called microcystic, and it is serous carcinoma. Okay? It's P53 positive and Ki67 positive, PAX8 and P68. Oh, let's move to endometrioid carcinoma. Look at this. Overall, it's probably chocolate cyst. This is the fallopian tube. In the middle of the hemorrhage, so you might have endometriosis. Sampling, sampling, sampling. Always sample the solid part and look at it completely. You know, because it's so easy to miss minute focus. It might be smaller than this. But grossly, this is the way it looks more cystic-like. And the key here, which is like a given key, seeing squamous differentiation. It's beautiful if you have it. You are right away in business. It's endometrioid endocarcinoma with squamous differentiation, or if you see the endometriosis. Okay, but if you put this in the endometrium, it's endometrioid. But believe me, not all of them are very easy. This is FIGO grade 3, endometrioid. Could be a little bit tricky and a little bit high-grade endometrioid though, okay? What about mucinous carcinoma? It has that honeycomb appearance, and you can see the mucin in, not all the time, but you could. There is two types of invasive mucinous carcinoma in the ovary. The expansile pushing margin, which behaves way better than the other one, which is the infiltrative part. But the mucin, you could see it. In every mucinous carcinoma, I do CK7 and 20. And why is that? To differentiate between the pseudomyxoma peritonei. That if it is CK20 positive, then it's coming from the appendix. If it is CK20 negative, it's coming from, this is another picture of it, 20 negative, it's ovarian most of the time. And the 7, I mean, this is a classic case. Sometimes you might see few cells, but always whenever it is diffuse positive, if it is diffuse positive CK20, think about appendix, okay? If it is diffuse positive 7, then most likely it is ovarian. And it is very rare, ovarian mucinous carcinoma though. Clear cell, it's arising from endometriosis most of the time. Whenever I have problem at the frozen section, think clear cell, you'll be right. Because in the frozen section, for some reason, does not reflect well the hapnailing, does not reflect well the hyalinized. So like, I know it's high grade, but I cannot tell the histologic variant. If you cannot in the frozen section, it's okay. Call the GYN oncologist and tell them it's high grade ovarian carcinoma. That's enough. He doesn't need to know more, even if he push you. Do not. Do you do frozen section on the ovary a lot? You don't. I know I gave the presentation about frozen section in England. Oh my God, they almost chewed me. They do not do it at all. We do frozen section for ovarian carcinoma, and it's really challenging, you know. So I made an agreement with my GYN oncologist. If it is not me, it's okay to call it high grade or low grade, just because of the management. Because sometimes they are curious, and I'm like, really, you want me to sweat for curiosity? No, thank you. So clear cell, hapnailing, it's clear cell, agree? You got it all. You got that clear cytoplasm. Sometimes it's not a clear cytoplasm, it's eosinophilic cytoplasm. But the key is, for me, the hyalinized core and the spectrum of cystic, microcystic, papillary, and the hyalinized core, okay? And this is the papillary variant, and this is the hyalinized core. Clearly clear, solid variant. More of it, hapnailing more than anything else. Hyalinized core. Just it's beautiful to take pictures of clear cell. They come good for some reason. And sometimes it gets challenging though. Look at this. It was like tough, but other foci was clear cell. Okay, quiz time. Are you ready? One case, and then I'll keep going. But just to keep you awake with me. This is a frozen section. Can you tell 100%? Honestly, no. You know, I would think about cirrhosis. Do you agree? I would think. You know, let's look at it. But it's too thick, right? But how many of you will say cirrhosis? Raise your hand. We got 5, 10. Endometrioid? Good. Actually, that was my debate. I went high power. Are you still endometrioid?